Hi everyone, welcome to today's video. We are in the quest of knowing the unknown things in medical field. Hope you are excited like me for today's diagnosis. Let's get started. It's a very fine week and the finest day in the Springfield city. Our Dr. James is resting in his cabin. Suddenly, a fragile voice of a woman came.
Doctor, I need your help.
James turned and saw a shaggy-looking old lady, very thin and emaciated, having perioral rashes. Dr. James asked politely,
Madam, may I know what is your problem?
I was thrown away from my home by my children. From then I started having depressive episodes. Severe pain in my legs. Painful rashes in around my mouth and buttock. I always felt tired and lost lots of weight and hunger. One day, I came to know that a good doctor is helping poor people in the city, and that's why I am here in front of you.
Our Dr. James measured the blood sugar, and he was surprised to see the random blood sugar of 500 milligrams deciliter. Dr. James suddenly ordered for abdominal CT. What do you think Dr. James is suspecting of? Your time is ticking. The answer is Glucagonoma or hyperglycemic cutaneous syndrome. If you have found it right, then a big applaud to you. What is Glucagonoma? It is a glucagon-secreting neuroendocrine tumor of pancreas. It usually presents in 6th decade without sexual predominance. Let's first look into the physiology of glucagon. It is secreted by alpha cell of isolated langerhans. Normal level is 150 picograms per milliliter, and 7 half-life is 10 minutes. It increases breakdown of glycogen and rises blood glucose level, causing hyperglycemia. It increases the breakdown of fat, causes weight loss and deep vein thrombosis. At high doses, it increases the cardiac contractility. Coming to the clinical picture, you have go remember 60s. 1. Diabetes mellitus. Due to increased blood sugar. 2. Dermatitis. The rashes is typical red, painful, pruritic and heals without scarring and appears in adjacent areas, hence called necrolytic erythema migrans. Presence as glossitis and cheilitis. 3. Depression. 4. Deep vein thrombosis. 5. Decreased weight. 6. Decreased hemoglobin. Now moving on to investigations. The investigation of choice is blood glucagon level, when more than 500 page per milliliter is diagnostic. Other investigations are somatostatin receptor scintigraphy, abdominal CT or MRI. Most commonly it is present in body or tail of pancreas, and presents only when it grows to a significant size of 10 centimeters. The treatment of choice is distal pancreatectomy plus octreotide, a somatostatin analog. Now our patient is completely cured and happy. Thank you for watching, and don't forget to hit that subscribe button and turn post notification on. Stay tuned for more videos. All the best for your exams. Finally, today's question. What is MAVASH disease? Know the answer? Comment down your answers below. Until bye from Dr. Harrison.